a neurology VMR. And first things first, who should be a co-host? So we can make sure we get that settled. Sarah, okay. Kiara, probably. Anyone else needs to be a co-host? Yasmin, excellent. Okay. And did anyone bring a case they wanted to discuss with us today, hopefully? Well, I'm co-hosting 25% of our folks here today. Oh, and the chat is busy. Sorry, I haven't been on one of these in a long time. All right. So does anyone have a case they would like to discuss? And we need two discussants, ideally one identifying as a woman, one identifying as a man, to discuss a neurology case this morning. Don't be afraid. The whole point of this series is to end your neurophobia. So we will all be able to learn together. Anyone? I see lots of people saying hi and hello, or is that you volunteering to discuss a case? Yasmin, I appreciate that. I think you discussed last time and the time before, so we want to make sure we have other people, give other people a chance, but you're more than welcome otherwise. Does somebody have a case, first of all, that will be important. Otherwise, we'll need someone to search for a case. Okay, Robbie has a case, amazing. Who would like to discuss this case? All right, Yasmin, you're in. Who would like to discuss with Ravi and Yasmin? Yeah, you're a co-host, Ravi. I think you should be. Anyone? Kiara? Excellent. Oh, Kiara, it's been a long time. All right, Kiara, Yasmin, Ravi, are we set? Kiara has discussed many times also, as Yasmin has, not to exclude them from their enthusiasm, but anyone else who was hoping to discuss and just waiting to the last minute who would like a chance? All right, you just saw Robbie has joined, so volunteer, so Robbie can see that we have not spent 8 minutes looking for a volunteer. Can a neurologist act as a discussant? Yeah, absolutely. That would be fun. Sridhara, are you a neurologist and you'd like to discuss?
Hey, afternoon. Yes.
All right, fantastic. Well, I don't think we'll do 3 discussants, so either Kiara or Yasmin, would you like to cede your place to Sridhara, who I didn't think has discussed before?
I'm doing teaching points, so maybe Jess can discuss.
Okay. All right, fantastic. Okay, we have our full cohort by 8:09, which is not too bad. So do you want to just introduce yourselves briefly, Sridhara, Ravi, and Yasmin, and then we'll go ahead and get started.
Hey, afternoon, everyone. Long time follower, just haven't been in any live cases for a while, so it's good to finally participate in one. I'm a vascular neurologist at Thomas Jefferson, and also an internist and hypertension specialist.
Fantastic. My hometown of Philadelphia, where I was born and raised. Good to have you with us discussing. And Ravi and Yasmin.
I'm Ravi, hospitalist at Sinai, Baltimore. Go ahead, Yasmin.
Yeah, hello everyone. I am Jasmine. I am a Mexican medical graduate. I'm really excited to learn from you, actually.
Excellent, fantastic. Okay, Ravi, why don't you go ahead and give us the chief concern, and we'll go ahead and get started.
Sure. So I have a case that's about 8 years old, presented at one of the morning reports. So we have a 44-year-old right-handed female, and about 6 days ago, she began to have right arm weakness, also weakness of a grip on the right hand. And I'll stop there.
Okay, fantastic. Yasmin, what's coming to mind here?
For me, first, I will think something vascular. It could be a stroke. I would definitely ask for, next thing, I will ask for past medical history, if there is any coagulopathy or anything that it's a female, right? I would definitely ask her if she's on any procoagulant medications such as OCPs, because the first thing I will think is if it's isolated weakness, I would like to know if she has a ischemic event, a vascular event. What do you think? But I'm very excited to see what Dr. Sridhara, I'm sorry if I said wrong your name, will think about it.
Yeah, great. Go ahead. Yeah.
Yeah, so when I approach a case like this, there's always two things I think about. There is think fast and think slow. Think fast is the first diagnosis that comes to mind, like you mentioned, vascular etiology, like an acute stroke or something intracranial. Then you slow down and say, okay, what else could it be? You want to think about intracranial etiologies other than vascular. You want to think about demyelinating. You want to also say, could this be outside of the brain? Could this be in the spine, like in the C-spine? And also you want to think about, could this be in the brachial plexus, or could this be in the muscles? And could this be in the hand itself? Because let's not forget, like someone gets a vascular occlusion from AFib of the hand, of the axillary artery or something, they can suddenly develop arm weakness and grip weakness. The most important thing that's going to help us out is the tempo and the associated symptoms. So what is the company that these symptoms are keeping? That's going to help us with localization and with etiology.
Yeah, fantastic discussion, both of you, right? Trying to figure out the localization, the time course, and then make sure we're not missing anything that would be emergent and require some type of emergent intervention, like a vascular event, right? So let's look at the localization a little bit, and Sridhara largely walked us through this, right? We have a problem in the right arm, and it seems like the right hand in particular. And so, as he said, this could be a lesion really anywhere along the motor pathways from the brain all the way out to the muscle. So just for review, right, we have the corticospinal tracts beginning in the precentral gyrus of the frontal lobe, and those tracts are running through the subcortical white matter through the anterior brainstem. So for the right arm, this has begun on the left side of the brain, descending in the left side of the brainstem, and then as it enters the spinal cord, it crosses over to the other side of the cervicomedullary junction and descends in the spinal cord. These are the upper motor neurons that are going to synapse on the lower motor neurons that begin in the anterior gray of the spinal cord and are going to exit through ventral nerve roots, form, in the case of the arm and hand, the brachial plexus, as Sridhara mentioned, and then divide into the individual nerves that are going to innervate the arm and hand. And then those are going to synapse on neuromuscular junctions and onto muscle. So where along this pathway could we be? Well, we have the hand and arm, and you might say, well, if we don't have any face, we don't have any leg, could we still be in the brain, or do we have to be somewhere below that? Well, we still could be in the brain, because if you remember the homunculus, the hand has a huge representation in the motor strip, right? And we're able to do lots of very dexterous things with our hands, from things we all do every day, like type and use our phones, to the highest level of, hand activity in some famous musician or athlete or someone who's doing all these very skilled motor activities. So you can get a lesion in the brain itself that will only affect the arm and hand, or maybe the patient has some subtle facial weakness that they haven't noticed because the hand is so prominent. So this could be in the brain on the left side. Probably not in the brain stem, right? If it's truly just the arm, because the motor pathway is, everything's really pretty packed tightly there. So you'd probably expect to get face and leg with it, if not some cranial nerves being picked off on the way down the brainstem. So that's probably not where it is. It could be in the cervical spine, as Sridhara said, and it could be a problem with the brachial plexus or one or more roots or one or more nerves. So it could be in the peripheral nervous system as well. A neuromuscular junction process just affecting one limb probably doesn't fit a muscle disease. Usually that's more diffuse, so affecting just one limb probably doesn't fit. So we're probably left with brain, cervical spinal cord, or periphery, in which case we'd be thinking about roots, plexus, and nerve. And we won't go too much down that rabbit hole until we see if this truly is in the periphery, because we'd have to do some very granular localization to determine, is this one nerve, multiple nerves, one root, multiple roots, or the plexus? And that would be a whole other topic. Okay, so this is going to be a sort of paradigmatic, quintessential, are we central or peripheral? And we'll address that as we go further. And then we have the time course, sort of, right? And Ravi has presented this in a way to us to leave this a little bit open, right? Because if this happens suddenly 6 days ago, then of course Yasmin and Sridhara both said, thinking fast, we have a focal deficit that's recent. We can't miss a stroke here, right? And so the question for the patient will be, did this happen 6 days ago and has persisted with the same level of weakness? Or is this a process that's been ongoing for 6 days and getting worse, in which case we'd be in the acute but not sudden category, right? And then we could be thinking, as Sridhara said, is this in this young person a demyelinating lesion in the brain or cervical spine in a first presentation of MS, or maybe not so first if we learn that they had some visual problem in one eye a few years ago and had optic neuritis, and maybe this is not the first demyelinating event. Other things that could fall into this time course and give us something focal in the brain or spinal cord, you could think about some type of infectious lesion, like an abscess. If the patient turns out to be immunocompromised and we don't know yet, the differential diagnosis for what could be in that abscess increases. For example, if this patient has known or yet to be known HIV, something like toxoplasmosis could present in this way with a focal, relatively acute but not sudden deficit. And then if we're in the periphery, most peripheral processes are not this fast moving. Guillain-Barré would be an example of a very fast moving peripheral process, right? But patients generally would it would not be focused in one limb. There are many variants of Guillain-Barré, but I'm not sure of any that would be so focal, unless this is the most prominent and there's some asymmetric weakness to go along with it here. And then condition probably might be new to some people. I didn't learn about it until relatively late in residency, is the brachial plexus can be affected by inflammation as well. Can get a brachial plexitis called Parsonage-Turner syndrome. And this is an inflammatory brachial plexopathy. Usually the patients describe a prodrome of severe pain in the axilla, and they often go to physicians and there's nothing really to see on exam and people aren't sure. And then the pain sort of resolves over days, and in its wake leaves weakness, usually of one arm. It can be both arms and asymmetric. And there are particular nerves that tend to be affected. There can be scapular winging from the long thoracic nerve, and difficulty making the OK sign from the anterior interosseous nerve, which does flexor pollicis longus and the flexor digitorum profundus of 1 and 2. And the classic history is that the patient has done some heavy exertion with that arm the day before. Chopping wood, I think, is in the old descriptions, or something like that. So the time course sort of, in some ways, constrains the localization here as well, because it's hard to think of something very fast moving in the periphery. In patients with vasculitis who develop mononeuritis multiplex, and they can get infarcts of individual nerves. So again, if this happened suddenly 6 days ago in one place, that could be something you could think of. But a 6-day progressive, puts us in the sort of infectious, inflammatory, toxic category in one limb, to me makes the periphery a little less likely, with the exception of an inflammatory plexopathy. Or if it was sudden 6 days ago, some type of nerve infarct, that's incredibly uncommon. So maybe even with the time course, makes us think a little bit more brain or cord here with this focal deficit. So those are the things on my mind. I agree with everyone. The not to miss diagnosis is that this patient have a stroke 6 days ago, and the history should help us a little bit there, or something that began 6 days ago and has worsened over that time course, which puts us more in the infectious, inflammatory, or toxic in principle, but a toxic focal arm something is, doesn't quite add up. Okay, so with those questions, concerns, thoughts in mind, Ravi, what did you find on the history?
Sure. So in addition to 6 days ago having this right arm weakness, she also started having some confusion, having difficulty organizing her thoughts when talking with others. Her family also noted that for about 2 to 3 days, she was slow to respond and react to surroundings. So sort of she was distant. She also mentioned that she had slowed down in her responses to questions as well as all activities and was confused by seemingly straightforward issues or simple issues. Also described this out of body experience. It felt as though the right arm wasn't part of her and her thinking was slowed. So it was slow to reacting when she was thinking about moving the arm. Just wait for the scribe to catch up. There was also a headache, a generalized headache, which has been a long-standing issue for the patient. So in the past medical history, you can mention also headache. Also endorsed night sweats, which began about 1 year ago and got worse over the last 3-4 months and gained about 15 pounds. And past medical history. So experiencing these headaches off and on since childhood or adolescence, and has been taking the following meds: Topomax and Reglan, and intermittent NSAIDs. Past medical history, other than the migraine, hypothyroidism. Family history, smoker, or family history, there's lung cancer and breast cancer. Social history, smoker, started smoking since 20 years of age, 5 cigarettes per day, occasional alcohol, no substance use. I'll get straight to the physical exam.
Oh yeah, maybe we'll just pause
Okay.
there, if that's okay, Ravi, unless there are many twists and turns and you're giving me a subtle sign to not take up too much time here. I'll take the time, but just do we have a moment, Ravi, or are there a lot more twists and turns? Yeah, okay, because it'll be nice to have some hypotheses going to the exam. Yasmin, what does some of this new information make you think as far as localization and possible diagnoses?
Yeah, just as Hans mentioned in the chat, the first thing I thought about with a patient that progressively starts having mental issue, like the AMS. Well, it's not altered yet, but it has been progressive, and she has had night sweats. And even though she has the past medical history of hypothyroidism, I may think of a mass effect, something that is progressively and slowly started to grow. And the first thing that comes to mind is a CNS lymphoma that can present with focal neurologic deficits, headache. It can present with nausea, and this and that can progressively worsen due to the mass effect. It increases the intracranial pressure that will start to give us this kind of presentation. But again, I think that that's a jump for me before like screening and imaging tests, but that would be my first thought. What do you think, Dr. Sridhara?
So this does definitely help us a little more with the localization. So when you're thinking about confusion, difficulty organizing thoughts, it's important to think about the frontal lobe, especially the dorsolateral prefrontal cortex, which is important for organizing thoughts. Another thing that you might see if there's an issue in this area is problems with gaze. So, you know, we didn't hear that in the history, but during the exam, when you're thinking about that, you should definitely check for gaze preference. And the other thing is the slow reaction. That is more in the medial frontal area. And if it's very severe and bilateral, people have what we call abulia, where they're just very slow to respond. You ask them their name and they don't say anything. You move on to the next question and then they say their name. They just have lost motivation. So, you know, also you can see these types of lesions in subcortical areas and basal ganglia lesions on the same side, like caudate lesions, etc. But that's a little more unusual. It does happen though. So, you know, with the hand weakness, with these other symptoms, you're thinking, okay, there is something in the cortex. There is something on the contralateral side to the hand weakness. And then, you know, based on the tempo, you're thinking, okay, one thing you want to clarify is, did the symptoms start and then stay the same, like Aaron mentioned a little while ago, or have they been worsening over the 6 days? Because worsening over the 6 days is a little unusual for a stroke. So you are thinking about infections, you are thinking about inflammatory causes, you are thinking about malignancies. The night sweats again makes you think of inflammatory conditions, whether it's infection or malignancy. And the weight gain is a little unusual, probably from the hypothyroidism. You know, sometimes patients can have as many diagnoses as they please. The chronic headaches, whenever we see chronic headaches, we always want to think if those chronic headaches or migraines can be part of a syndrome that can cause other neurological manifestations. We see this sometimes in stroke patients with genetic syndromes like CADASIL. We see this in patients with mitochondrial conditions where they have history of other things, like headaches, migraines, and then, you know, they can present with a stroke or present with a brain mass like lesion, which is seen in TREX1 mutation conditions. So again, you know, could that be something unrelated, or could that be part of the patient's presentation now? You always want to keep both lines of thinking open. The smoking history, you know, puts her at risk for cancer. It puts her at risk for vascular disease. So that does still keep vascular condition or inflammatory or infectious or malignancy all on my differential for potential etiologies.
Yeah, brilliant discussion there, both of you. I don't have too much to add. Yeah, your localization was extremely nuanced there, not just telling us, well, now we know there is confusion. We can take off the peripheral nervous system. We can take off the cord. We are in the brain here. And you gave us a very beautiful discussion of how we can even go further to say where specifically in the brain, particular cortical regions, subcortical areas, and networks of those that give rise to attention as seems to be impaired here. So, right. So the fact that there is confusion puts us in, squarely in the brain. Can we make this all one lesion is a question we try to ask ourselves, or does this seem like it's more than one lesion? To have this degree of confusion, and so let me back up. So we have the right arm weakness, and if all of this is one lesion, then we need to be in the left brain. And if we're in the left brain, can we have one lesion in one hemisphere sufficient enough to impair the patient's mental status this much? I suppose we can. We're not hearing something specifically about language. It sounds as though we haven't heard, at least yet, and we'll find out on the exam, if the language is impaired or the patient is merely slow. Can you get sort of the slow abulic, Sridhar used that term abulia, sort of a very decreased speed of response, as Sridhar gave an excellent description. You ask the name, you don't hear anything, and a few questions later, patient answers the name. One of my mentors said he remembered a case where they asked the patient a few questions on rounds and the patient didn't answer, and then they continued their rounds, and the nurse came and found them much later and said, this patient wants to talk to you, and they went back, and then the patient answered the question from, you know, several patients later, so a long time ago. Or patients, when you examine their mouth, or still have dinner from last night there, they just sort of, the motivational circuitry is so low that patients just sort of stop and are so slow that they're so this is called abulia, as Sridhar mentioned. Could you get that from a unilateral lesion? I'm sure there must be some way to do it, but I would think of that a little more bifrontal. to really be that impaired. And we're hearing about this sort of slowed reaction without a specific impairment in language. So part of me does wonder if this is a multifocal process within the brain, where you have a number of smaller lesions causing this mental state, and one of them happens to be larger, causing the problems in the right arm. So one of the left frontal lesions. It's a little hard for me, at least the way I'm picturing this state, the way Ravi has so described it in such detail, does make me wonder a little bit about whether we're dealing with one lesion or more than one lesion. And then before we get into all the interesting information that could help us figure out what that is, it sounds like the patient is accumulating deficits. If the arm's been going on for 6 days, and then a few days later, there's this confusion, there's this out-of-body experience, which might be some type of seizure. So the sense I'm getting, and Ravi can help us clarify, is that the patient is accumulating deficits over this period rather than that one thing happened 6 days ago and the patient is now presenting. So what would cause this patient to accumulate deficits? Well, Yasmin mentioned some type of mass that's rapidly expanding. Tumors don't typically expand this rapidly over the course of days. An abscess or something like that could do. If the patient is having some type of fulminant demyelinating syndrome. So we think of MS as causing these relatively small focal lesions, but you can get these fulminant demyelinating syndromes like acute disseminated encephalomyelitis. That's more common in children and can be associated with an antibody against MOG, myelin oligodendrocyte glycoprotein, and they get multifocal lesions that can be associated with that antibody or can be post-infectious. Oops. And then other fulminant demyelinating syndromes, there's tumefactive demyelination, which looks like a tumor, but is actually some large and expanding demyelinating lesion in this age group, something we might think of. Then when we kind of superimpose that on night sweats for a year, we could think of inflammatory or malignant processes, but the patient's relatively young, and then a malignancy moving along this quickly seems a little unlikely. An inflammatory process, we've mentioned some of those, but the demyelinating diseases aren't usually associated with night sweats. So I wouldn't be too sure what to do with that. The weight gain and the hypothyroidism, is there some type of endocrinopathy here? But how to relate that to what seems to be, if we just had the confusion, we could wonder about, endocrinopathy or something causing elevated intracranial pressure. But we have the focality also of the arm. So it does suggest to me that there are structural lesions here. Yasmin, you mentioned elevated intracranial pressure and whether there's some mass that maybe has been there for some time, but things have tipped over on the intracranial pressure curve, and now the patient is intracranial pressure is rising abruptly and causing this mental state. And so maybe that could explain a focal lesion followed by a more generalized state of confusion, but still it's all happening very quickly for a tumor to do that. So what are we left with? I think we're left with some type of multifocal brain process or a very large left frontal lesion. And the exam is going to help us tease that apart. And then over this time course, accumulating deficits, you could think of infectious processes. We've mentioned inflammatory. And I suppose the other process would be, is this patient having, has had several strokes, right? Has some type of process like endocarditis where they are having continuous series of strokes. So they had one stroke to cause the arm, and then a series of small emboli that are now disrupting the mental state. And so then maybe there we can talk about, well, a year of night sweats. I don't think you'd get that far with endocarditis, but if the patient has some type of more subacute or chronic, more subacute endocarditis that has been there not for a year, but for maybe days to weeks, and is now having strokes as a result and picking off different smaller vessels and accumulating deficits in that way, could bring us back to one of the initial hypotheses. So I think our questions for Ravi are, is this a one process that's kind of in crescendo, or is the patient developing multiple deficits, to clarify on the history? And then what will help us? Well, let me ask you that question actually first, Ravi, before we go too much further down that path. Are we discussing this in the right way? The patient has arm weakness that's worsened over a few days and is accumulating mental status deficits on top of that. Is that correct?
Right, yeah.
Yeah, great. Okay, so with that in mind, what will help us on the exam here? Let's have maybe Sridhara, tell us, as you go to examine this patient with these hypotheses of focal versus multifocal, and with some of the differential diagnosis on our mind here, what are you looking for specifically on the exam? Then we'll hear the exam, we'll have Yasmin interpret it. Oops, I think you're muted, Sridhara.
You could do a neuro exam the whole day if you wanted, but what you're
Yes.
basically trying to do is test your hypothesis. So we are thinking, okay, is this a multifocal process or is this just a cortical, like frontal lobe process? Some of the things I already mentioned, I'm looking for any gaze preference when I see this patient. I am looking for any frontal release signs. Sometimes you can see these signs where there's enhanced like um, snout reflex, or there is when you scratch the thumb, you might see the lip muscles contract, or you might see other frontal release signs like that. That is something I'm looking for. And definitely I'm looking for language, because language is a big part of the frontal lobe. If your frontal lobes are affected, you do expect that production of language and speech is going to be affected. I'm looking at inattention. The way we test for that is we have the patient spell backwards or do serial sevens. And the other activities we talked about, like trail making testing and other things, you can get into more of those. But if the patient's inattentive, you expect that most of your testing is going to be affected. I am also looking at the usual testing: cranial nerves, motor, sensory, and reflexes and cerebellar. If your sensory cortex is affected and there is no like dense sensory loss, you can actually test for that by doing things like 2-point discrimination, or putting something in the patient's hand and asking them to tell what it is they're holding. They will have sensation, but they won't be able to tell you what they're holding. That tells you, localizes to the cortex. As far as motor is concerned, if your cortical lesions, unless they're very big lesions, if your hand is affected, your leg is not affected to the same extent as your hand. And same thing with the face. If your face is affected, it's usually the lower face. If you ever see face, arm, and leg are equally affected, that's very hard to do in the cortex without having a big lesion. So just thinking these things through: the sensory, the motor, and then the cognitive frontal lobes, and then the language, and then the eye fields. This is very helpful. If your lesion is extending into the parietal and other areas, you might see peripheral vision loss, which can often be missed unless you're specifically testing for it. So that is also something I would look for. So that should help us tell if this is cortical or not. Now, if you start looking at reflexes and you see some hyperreflexia in the hands without any other hyperreflexia, that also helps you localize. It localizes to the corticospinal tract, doesn't necessarily say it's cortical, but if you have all these things, then you can localize to the cortex.
Brilliant discussion here, right? We know we're in the brain, at least one or more lesions in the brain, but very nuanced discussion here about all the different ways we can test the mental state in particular to try to get a sense of, is this a general sort of more non-specific encephalopathy presentation, whereas Sridhara said, a very important point to highlight, if the patient is inattentive, and how would you test that? Maybe asking them to say the days of the week forward and then backward. It's hard to say them backward. We don't usually do that unless you're a neurologist and you ask people to do it every day and you remember how it goes. And people can get a little bit lost in the task: Saturday, Friday, Saturday, Sunday. They are even inattentive to what you've asked them to do, right? So if the attention is impaired, the important point that Sridhara had said and I had wanted to highlight is that it makes it really hard to test memory and all of these other tests, right? Because the patient is inattentive, and attention is sort of the doorway into the rest of the cognitive modalities. If you're not paying attention, you can't form a memory, you can't have a meaningful conversation if you're not holding anything in short-term memory. So if the patient's sort of inattentive and we can't really test much else, that's usually less focal and more generalized, which could be some type of toxic metabolic or medication or medical etiology, but here we do have some focality to account for it. Whereas if the patient is attentive and has a particular language deficit, that may help us localize a little further. Or if the patient's language is truly intact, but just slow and sort of confused in content, then we might be thinking about a more generalized bihemispheric, particularly bifrontal process. And then you mentioned if we see the gaze deviated, that could suggest one of the frontal eye fields is out. And so if this is really all one unilateral left-sided lesion that's big enough to do all of this, we might expect some gaze deviation. Although you can tell me, Sridhar, I've only seen sort of true gaze deviation in the setting of vascular insults, right? Even large tumors, large infectious hemispheric lesions can cause all sorts of contralateral deficits, but usually not gaze deviation. I feel like for some reason, that is a hallmark of stroke. Is that your experience also, Sridhar? Have you seen gaze deviation with a big non-vascular lesion on one side?
I feel like if it's something sudden and the brain hasn't had time to adapt, that's when you see it, like seizure, stroke, or hemorrhage.
Seizure, right?
But
Yes.
otherwise, you don't see it if the brain has had time to adapt.
Yeah, great point. Maybe it is an adaptation phenomenon. I hadn't thought of it that way. That's fantastic. Yeah, right. So seizure, of course, another. So that could be a focal lesion driving the eyes. Yeah, but sort of a lesion without seizure causing eye deviation, right? That's usually going to be an acute stroke or a patient who's had a stroke, and the gaze may remain deviated to some extent in those patients. Okay, so we have a good sense, and of course, we're going to check the whole exam to see what other clues we have and see if we can come out of this exam answering the question of, is this in one hemisphere or both, or if there's any other clues that help us with the etiology. And then we know an image is waiting for us after that, and it's probably going to offer a lot of the answers we're looking for, but we'll do this the old-fashioned way and see what we can tease apart on the exam. So what did you and your colleagues find, Ravi?
Sure, starting with vital signs, temperature 36.7, heart rate 79, and blood pressure 112/73. Rest of the vital signs were fine. The general physical exam was normal. Just talking about the eyes, pupils were equal, round, reactive, extraocular movements intact, normal conjunctiva. And then just jumping to the neuro exam. So starting with the mental status, attention span and concentration was normal. And then level of consciousness, alert or interactive, oriented ×4. Memory, there was good recent and long-term memory, short-term memory normal. Patient had adequate fund of knowledge. Regarding cognition and comprehension, speech and language was normal, cranial nerves intact, although there was a questionable mild right facial droop at rest, but symmetric with smile. Sensation within normal limits. And then muscle tone and motor function, normal bulk and tone throughout, no weakness in the upper or lower extremities bilaterally, no drift, no appreciable right upper extremity weakness. And then highlighting coordination and gait, there was a negative Romberg's test. And then the right arm was found to be clumsy on rapid alternating movements. There was also an unsteady heel to toe straight line test. And then reflexes, they found an upgoing toe on the right and equivocal Babinski reflex on the left. Just to sort of summarize, to give you a problem representation, a 44-year-old female with a past medical history of hypothyroidism, migraine, presenting with right weakness and confusion for 6 days with exam findings of right arm, which is clumsy on rapid alternating movements, unsteady heel to toe, straight line test, and upgoing toe on the right, and equivocal Babinski reflex on the left. And I can stop there.
And just to confirm, Ravi, the mental state that her family had described, there was no objective evidence of that on the exam.
Absolutely none.
And how was that explained or discussed with the family? Is that she had a period where she was like this and had now recovered, or she looks normal to the doctors, but they're saying this is not her?
Right. Exactly what you meant. Yeah, what you said. So yeah, at the time of presentation, she appeared normal, but she seems to have fluctuating status.
Fluctuating status. Got it. Okay. Yasmin, you can pick one or more or all of these findings. And how does that help us here with localization and differential diagnosis?
I am thinking of, like, when I'm listening to the upgoing toes on the right side and the Kivika Babinski of lower side, if that's not wrong, that will be an upper motor neuron lesion. And I will be thinking, like, if whenever I see an up reflex, I will also see if there's uptone, if there's also like appreciable weakness, so it will be also like less power in these muscle groups. So these kinds of, whenever I think of upper motor neural lesions, I would think maybe multiple sclerosis, a stroke, again, a mass tumor, or something more simple such as vitamin B12 deficiency, but that would have another, it will be accompanied by more things. Now, if I remember well, it also had a case of, she also had a gait issues. Was it normal, the gait? I don't know why, but I thought that it was not
Yeah,
normal.
normal gait. Yeah.
Okay. Well, this clumsiness also locates me in the cerebellum, thinking if there is any issue there, being vascular or also being something that is compressing the cerebellum, because this lack of coordination, especially on the, it would be, I will think cerebellum too. So I don't know what you think.
Yeah, great. So yeah, when we hear that clumsiness on rapid alternating movements, that does suggest something cerebellar. And I think Ravi had mentioned the finger chase, which is sort of a cousin of the finger nose, where you ask the patient, you move quickly and have them try to mirror you, and they might overshoot and come back. Those do sound cerebellar. If a patient is weak but not paralyzed, it can be very hard to distinguish whether the movements are ataxic or just they're weak, and so weak and a little bit slow. Because cerebellar lesion shouldn't cause an upgoing toe, right? As you said, Yasmin, that's somewhere in the corticospinal tract. And the cerebellar hemispheres communicate with the ipsilateral limb because they communicate with the contralateral brain hemisphere. So if you had a right-sided cerebellar lesion that was big enough to get into the right-sided brainstem and the right-sided corticospinal tract, you should actually have a left upgoing toe. And so is this all just weakness of the right arm and slowed movements due to a corticospinal tract lesion that are appearing clumsy, or is the patient truly ataxic? And if they're truly ataxic and it's in the right cerebellum, then we have to invoke two lesions, a left corticospinal tract lesion and a right cerebellar lesion, and then we have two things here. So a little bit challenging. And then we hear that the confusion is not present. That's why I wanted to clarify. Sometimes the family will say, this doesn't look confused to you, but this is not the normal personality of this patient. That's very powerful information to know. Or, well, now they're okay, but they have been very confused. That fluctuation might make you worry that there's some type of seizure process superimposed here, a non-convulsive seizure, that the patient is has a fluctuating mental status. You shouldn't get seizures from the cerebellum. So again, either what looks like ataxia is actually weakness and slowness of movement, or we have multifocal lesions, something hemispheric, to cause both the upgoing toe and a focus for seizure, and the cerebellum, and then we're multifocal. So we've known since the chief concern, as both Yasmin and Sridhar said, this patient is going to get brain imaging. But it's helpful to try to think through cases in a way that's becoming increasingly rare before we see the imaging based on the data, and very important to do, because even though neurology might have been consulted after the imaging was obtained in the emergency room or by our internal medicine colleagues, imaging is so you can see such detailed imagery of the brain now that you might see subtle findings that may have no relevance to the clinical presentation. So some people say, oh, with the imaging, you don't need to do this whole localization thing anymore. Well, you do, because there might be things that we see that are not accounted for on this imaging. On the other hand, things on the imaging that don't explain the presentation. And so we really have to use those together. So we're going to get a picture of the brain now, I'm nearly certain, from Ravi. Before we get that, Sridhar, what do you think we're going to see there? Do you have a sense of what the diagnosis is here, or have you narrowed it to a few possibilities?
So, the one thing I do want to add is bedside cognitive testing can definitely miss cognitive impairment. I have seen that happen time and again, especially in high functioning individuals.
Mm-hmm.
I think that's where activities of daily living is super useful. The clumsiness, like you said, I'm not hearing any other cranial nerves or any other long track signs except the corticospinal, and no other features of ataxia like speech or eye movements or anything. So I'm debating if this is going to be cortical on the left with either a mass of some sort, or like an abscess or a mass. That's what I'm thinking right now.
Yeah,
with that.
yeah, great thoughts. Yeah, it's not entirely clear, but I think it's always important in the situations where we do proceed in the order that we do in morning report, which does happen, right? A patient comes to clinic and we say, well, you need imaging. Before the imaging comes back, I always try to do, and I always encourage our trainees to try to do, think what you're going to see there, because if it matches well, then you sort of put that in your brain puts that in the column of, oh, my prediction and what I predicted and what was found are well aligned. On the other hand, if it doesn't match, there's a good emotional valence for learning if I really thought this was going to be normal and it turned out abnormal, and it reframes your clinical reasoning and tweaks it a little bit for the next time. Or I really thought this is going to be abnormal and normal, vice versa. I really thought this was focal versus multifocal. How do I square this with the clinical presentation so I'm a little more precise next time? So, we are hearing clumsiness without any appreciable weakness. And so if we take that at face value, it does suggest there's something in the right cerebellum that would not explain the right upgoing toe. So we may have a cerebellar lesion here, and maybe there's a previous lesion that's causing the upgoing toe on the right, and maybe even on the left, we heard it was equivocal, which may mean that it wasn't clear. When the Babinski sign is clear, it's clear. It's very kind of, this toe comes up very slowly, the other toe is spread. It's very clear, like if you see in a baby. When you see that in an adult, it's clear, it's up. Then sometimes it's very clearly down, all the toes curl, and sometimes it's ambiguous. And I've heard people say, oh, the Babinski's not useful. You'll see a bunch of neurologists sitting around debating, is it up or down? When it's up, it's up. When it's down, it's down. And sometimes it's not clear. And sometimes it's mute, meaning nothing happens, and you sort of wonder, is that sort of normal or abnormal if the patient has normal sensation in the plantar surface? So here, what if this patient, the acute lesion we're seeing here is the cerebellum, is the right cerebellum, and the patient has had a remote insult to the nervous system in the brain or cord that's giving one or both upgoing toes, and our initial hypothesis going back that this is in the acute but not sudden category, is this inflammatory? Does the patient have a new MS plaque in the right cerebellum in the white matter, and the upgoing toes are from some prior MS demyelinating lesion in the cord, if both Babinski's are up, or in the brain or cord if it's just one. This still wouldn't explain the fluctuating cognition. Multiple sclerosis, I believe, does slightly increase the risk of seizures just because there's so much damage to the brain over time, but as part of an acute demyelinating process, seizures are generated from circuits involving the gray matter. So, an acute white matter lesion in principle shouldn't cause a seizure, although it's obviously affecting the overlying gray matter. But seizure as part of a multiple sclerosis flare or part of the early phase of the disease would not be something I would think of, and I don't believe is something that occurs, or if it does, it would be extremely infrequent. So I'm not sure, and I appreciate not being sure, because it means Ravi is challenging us and we're going to learn a lot from this case. But I think there's got to be something in the right cerebellum, and there's got to be something in the brain here to explain this. So I'm going to stick with a multifocal process here. And so we have a multifocal acute process, and we're back to, has the patient had a few strokes, and we're going to have to figure out why. Does the patient have an acute multifocal demyelinating process like ADEM or a fulminant demyelinating syndrome? Are we going to learn that the patient has some type of immunocompromise due to HIV, and now the patient has multifocal toxoplasmosis or CNS lymphoma, which Yasmin had mentioned earlier? So I'm not sure, but I think we're going to see a multifocal process, and this might be a case where, although I'm sure the patient got basic serum labs, seeing the brain imaging might push us to get particular labs, like looking for HIV, if we see multifocal ring enhancing lesions. So I think all I can say is multifocal, and if we're in the acute category, there's been strokes accumulating over time, there's a fulminant demyelinating process, or there's a multifocal infectious process. So what happened next, Ravi?
Awesome. The discussion is searingly on focus. So I'm going to cut to the chase. So the labs were pretty much unremarkable. Hemoglobin was 14, so very good. No anemia there, or not even sign of inflammation or leukocytosis. I'm going to share my screen and show imaging. Give me a second there. Okay. Do you see the images, hopefully?
Yes.
And so these are the CAT scan wasn't as indicative of these lesions. So I just want to cut to the MRI because it really just did show these findings. And I don't have any accompanying description, but if you're Aaron, if you're able to take a look and describe, but it's pretty prominent there. What you see?
Yeah, absolutely. Well, Yasmin, do you want to tell us what you see there? And I would say, tell us what you see in radiology terms. You don't have to tell us the diagnosis, but just what you see.
I'm thinking this look like a 2 ring enhanced masses. And again, for me, it would be toxoplasmosis because cysticercosis, well, in thinking about infection, neurocysticercosis looks for, normally is more multiple ring enhanced and smaller. So this is, maybe I'm anchored because of my training, but I will first think if this lady is in contact with animals or has some kind of immunocompromise because she has, this looks like toxoplasmosis. Again.
Okay, let's pause there. So always helpful first to just to say, because as you said, it's easy to get anchored bias by all the things we've spoken about, as you acknowledged, Yasmin, and as we all are. But important, as you did first, and that's why I wanted to pause you, is to try to be like the radiologist who hasn't seen the patient, who doesn't know the context, right? Who's just saying, what do I see? And what you see here are T2 flare hyperintense lesions in the left hemisphere where we expected them to be. They're T1 dark. You may be showing us on that DWI sequence that they may be diffusion restriction. We need a corresponding ADC to see if they're dark. But that's all we can say so far, right? Now we have a big differential, as Yasmin said, but to stick there, we can't say that these are ring enhancing because we haven't seen the post-contrast scans, and I suspect Ravi's going to have them on the next screen. But we can say these really don't look like infarcts, and they could be infectious lesions. Could this be fulminant acute demyelination? Could look like that. They're a little bit round, and that's why the contrast enhancing sequence is going to be helpful to us. They don't quite look like the classic phase of neurocysticercosis, which is usually circle with a dot and has CSF in the middle, which would suppress on flare, or cyst fluid, which should not CSF, should suppress on flare. Although there are many stages, and you can get fooled. So I'd want to see, and I think Ravi is going to maybe show us next because I see page 2 out of 4, some post-contrast scans.
I actually don't have them, but there's additional imaging. Debating whether or not to show them because of time constraints. But
oh yeah, we'll accelerate here. Were these indeed ring enhancing on post-contrast, Ravi?
Yes, they were.
They were. Okay, so Yasmin, your intuition was strong here and went further than the images we saw. So these are the only lesions, Ravi? Nothing in the cerebellum?
Nothing in the cerebellum.
I see. So shows us here that a weak limb can look ataxic because it's sort of weak, slow, clumsy, but not truly ataxic. Okay, so Yasmin had such a strong intuition of what the radiology would show that she could see the contrast imaging, although it wasn't available to us, and know that there were ring enhancing lesions here, and there were 2 of them. And that has its own differential. So in the interest of time, we would certainly want an HIV test. Could this be toxoplasmosis? Usually for a toxo, I would expect actually a lot more edema around these. And we don't really see any, we see a little edema in the shape of this sort of circle that has a ring around it, we know on post-contrast from what Ravi told us, but we don't see any shift of the midline despite it being close to the midline. That would make toxo a little less likely to me, though not impossible. Metastases, though, why would you get 2 metastases to one hemisphere and not to the other if this is a metastatic process? Not impossible. She's a little bit young. There's some smoking, but not a lot, though you can have cancer at any age. And these don't have the classic demyelinating appearance of sort of being a little more ovoid, but I think that remains a possibility. So I think we would want HIV testing, maybe some probably HIV testing is an important branch.
Just want to add.
Yeah, please. Yeah.
Lymphoma can be diffusion restricting, right? Like if the diffusion can be believed. So can a cerebral abscess.
Yeah, excellent.
So that might help us out in this case. Although you're right, there's not much edema around these lesions, which is a little unusual for cerebral abscesses, mets, and tumors, and toxo. So yeah.
Yeah. Excellent points, right? So we think of diffusion restriction in infarct, but anything that restricts the diffusion of water molecules, which infarct can do due to cytotoxic edema, but also abscess also primary CNS lymphoma due to all those tiny packed B cells. Again, to get 2 lesions on one side would stretch the imagination a little bit for infarct here or primary CNS, but really anything here. So I think HIV will be an important branch point if that's negative. 2 abscesses next to each other, 2 tumors next to each other, nothing on the other side. I think I would be more on the side of demyelination in this case. But tell us what happened next. Probably an HIV test, maybe a lumbar puncture, and we'll go from there.
Okay, yep. So HIV test was negative. They also performed a CT, a pan-CT scan looking for possible metastasis, although your discussion there was right on point that it's very unlikely, but still they had to do due course and do the scanning. It did show a little lingular lesion, although nothing concerning, especially with a smoking history. And then the patient was also discussing morning neurology departmental rounds to see what could be the cause of this. They did also have an MRI performed, CSF LP performed, which it didn't really, like coming through the data, really didn't produce any findings, nothing there that was anything that was remarkable. All studies for toxo, Lyme, VZV was negative. Also then looking for MS, they didn't really find anything that was or had a certain signal for MS. And then the immunological studies on the CSF also didn't show anything. Looking for other things, ANA, CRP was actually pretty low and normal. The ANA was 1 to 640, the titer, and rheumatoid factor was 15. And then VDRL was non-reactive. And then hepatitis was negative. And then they looked for other possibilities, doing an MRI of the T-spine and C-spine. And do you want to stop and discuss there before I
let's
do that?
pause there. Yeah, Sridhar, what do you have? All the data we're going to get until I think what's going to reveal the final diagnosis. So just since we're getting to the end of time here, just your thoughts here on what all of this data helps you.
Yeah, I'm gonna go with either demyelinating or if that's unlikely, then and we don't see any other lesions in the spine or anything like that, then a lymphoma would be something I would definitely consider with her night sweats for a year and with these 2 lesions. But demyelinating is what I'm leaning towards.
Yeah, good point. I had sort of forgotten about those night sweats and weight gain, and I don't think we have a good way of linking those. So yeah, this is a case where a careful review of the imaging and a careful review with neuroradiology would be very helpful. One question we would want to have is there a complete ring of enhancement? Does the ring seal completely all the way around, or is it an open ring or C-shaped enhancement? Because the latter is relatively specific for demyelination. So those are the only lesions. They look for metastasis, malignancy, which, as we said, is unlikely but important to rule out with multifocal brain lesions. HIV, because there was a question here of toxoplasmosis, although we said the imaging wasn't quite classic, but as Yasmin said, certainly possible with that ring enhancement. And then the spinal tap doesn't really show any inflammation. Often the tap doesn't show any signs of inflammation as far as protein in cells with multiple sclerosis, but should show oligoclonal banding, which we didn't see here. And so that being said, I'm still with Sridhar that this looks more inflammatory. So what else could we do? We'd like to try to avoid a brain biopsy in an eloquent region in this young, healthy person. So more tests, right? What could we do? Image the rest of the central nervous system and see if there's anything else there. And if there are smaller, more classic MS lesions, maybe we say this does maybe look more like an acute demyelinating event of some sort, either that the patient has evidence of older lesions or has multifocal new lesions throughout the brain and spinal cord, but is not systemically ill. We're not finding clues elsewhere. Maybe this is some demyelinating process, although the lack of inflammation in the CSF doesn't exclude that, but doesn't help us take that over the finish line. So I guess I would get more imaging, and if we really find nothing, we might consider, and the patient is not immunocompromised and has no risk factors for tuberculosis or other things that could be hiding and fool us here, we might consider an empiric course of steroids. and see what happens to the imaging and the patient. And if it goes away, think this was some type of acute inflammatory event, and keep a close eye with imaging at an interval follow-up. And that means we've
one thing I
out,
want to add is
yeah.
lymphomas can also go away with imaging. But they do come back once you taper the treatment, and that's how you usually know.
Yeah.
Yeah.
Very good point. Yeah, if we're concerned about CNS lymphoma, it's inflammatory cells, right? So those can melt away with steroids. And I have seen patients who are thought to have demyelinating disease get steroids, get better, relapse. They keep getting treatment for demyelinating disease. Finally, someone does a biopsy and it's lymphoma. This patient would be pretty young for a primary CNS lymphoma. We got that body imaging to show us there's no lymphadenopathy, to make us think of another systemic inflammatory disease with CNS manifestations, or a systemic lymphoma. Anything is possible, but usually primary CNS lymphoma in the non-immunocompromised patient is a single lesion, and it's usually homogeneously enhancing and not ring enhancing. So lymphoma, I consider one of our generation's great imitators, and it can look a lot of different ways on imaging, so we have to keep it in mind. But I think the two lesions, the age and the ring enhancing, make that seem a little less likely, and I think I'm still with acute demyelination. But yeah, what did you and your colleagues find next in the imaging, and were you able to make the diagnosis without a brain biopsy?
Sure. I'll give you this imaging and then let you discuss before we get the final diagnosis. So,
okay.
MRI, she actually came from a neighboring hospital with a C-spine MRI, which was unremarkable, but a T-spine was done, and it found a subtle signal brightening in the myelination within the mid and lower thoracic cord, from about T7-8 disc base to the conus medullaris. No evidence of cord edema or expansion or enhancement with gadolinium, and this is concerning for demyelinating disease.
And you said T7-8 all the way to the conus?
Yes.
Yeah, all the way to the conus. So what does that make you think, Sridhara?
Yeah, so if it's more than 3 segments, we're thinking longitudinally extensive transverse myelitis, and that should make you think of things like MOG antibody-associated disease, which can have intracranial lesions, and also neuromyelitis optica, and also Sjogren's. So some of the causes are, and antiphospholipids. So all causes of longitudinally extensive transverse myelitis.
Yeah.
But MOG antibody is looking like a suspect here.
Yeah, excellent. I agree with you. So neuromyelitis optica is sort of a carve out of MS with a specific biomarker, antibody to aquaporin 4. And then in seronegative NMO, it's then been discovered that MOG, myelin-associated oligodendrocyte glycoprotein, is sort of a carve out of NMO. So when you have a transverse myelitis that's spanning more than 3 levels, as Sridhara said, longitudinally extensive transverse myelitis, you have to think of NMO. Sjogren's can do that. Radiation injury can do that. You can get the illusion of a transverse myelitis with a dural AV fistula that's causing a lot of cord edema across the cord. But down to the conus, I agree, I think is something that's seen in MOG. And so I think this patient would need NMO antibodies and MOG antibodies to be tested. And I think this falls more in the MOG category, also because the brain lesions look a little bit more like ADEM than the classic NMO lesions, which tend to surround the 3rd and 4th ventricle, although there are many patterns you can see, including mass-like lesions and sort of callosal lesions, have all these nice names: cloud-like enhancement, arch and bridge, callosal lesions, etc. So I'm gonna go with ADEM, because there is encephalo and there's myelo, and I'm gonna wonder, you said this was 8 years ago. I don't think we knew about MOG then, but maybe the patient was followed and retested and found to have the MOG disease, MOGAD as they're now calling it, MOG-associated disease.
Yeah, interestingly, at that time they went with, because of MS falling on this spectrum between this MOG and then with the lesions, they thought possibly, like you'd mentioned earlier on in the discussion, tumefactive MS. So that's what they thought this patient had, but then this patient had to be or was followed up at the neurology clinic at Hopkins, and then they took over their care. I don't have the follow-up diagnosis, but MS was pretty much the diagnosis with the spectrum, including everything that you discussed from ADEM to tumefactive MS.
Very interesting. And Ravi, what ultimately was the explanation for this systemic stuff that we weighted heavier early on, and then as we got to the imaging, sort of thought probably not related?
I really don't have an explanation. This was a case by one of the residents, Yuan, who's up in New Hampshire. So I don't have the details about that. It was presented about 8 years ago. But yeah, it's kind of interesting. Some of that, like you had mentioned, I think you were right on point that some of this could have been explained by this hypothyroidism and possibly not being. I think I didn't have a TSH, but I think the patient was also non-compliant with the medication. So some of this could have fallen on that.
Interesting.
I think if you can see the axial images on the imaging, MOG has a specific pattern. It looks like a TIE fighter for the Star Wars fans. There's enhancement of the gray matter, and that might be helpful in diagnosing it. Yeah, so good case.
Yeah. Yeah, excellent. Well, thanks for bringing this complicated case, and thanks for presenting it in this way, Ravi, that allowed us to talk about many different things. I'm so glad I didn't go off on the brachial plexus in the first aliquot. I was tempted for talking about the arm. Glad we left that aside, since this moved away from things that can cause isolated arm weakness to a very interesting discussion of whether something is focal, multifocal, both hemispheres, one hemisphere, and here a possibility we didn't think of, right? Multifocal in one hemisphere, how to correlate the imaging with the clinical, and then coming back to first principles, right? This is a young, pretty healthy woman with something happening in the acute time frame in the central nervous system. When you frame it that way, it's hard not to think about demyelinating disease, especially once we've ruled out HIV infection. And so the only things that maybe threw us off a little bit were ring enhancing, though you can see tumefactive MS, and maybe it was an incomplete ring, and then the lack of inflammation in the CSF and lack of oligoclonal bands. But I think this is a sort of imaging clinical correlation. And in this context, we would certainly think of demyelinating disease. And 8 years ago, we probably would have called this ADEM, as Ravi said, and now we'd be checking MOG. And it just shows how rapidly the field of neurology is advancing, that since I've exited neurology residency, new diseases are being described, and we're rethinking old cases and finding that they have biomarkers of new diseases that have new treatments. So I know we've run a little bit over, sort of. We didn't start until 9:10 because we had trouble getting volunteers. So I'm still going to call this within about an hour. And for those of you who would be free to stick around for Chiara's teaching points, that would be great. And I want to thank Sridhara and Yasmin for the excellent discussion. Ravi, again, for bringing this very educational case. And Chiara, take us home.
Thank you, Ravi, for presenting this challenging case. This was amazing. So we first started with a great approach with Dr. I'm sorry. First, we started with a great approach. Doctor said that we first have to think fast. So the first diagnosis was like a vascular probably disease. However, when we think slow, we have to think about all the neural pathway, which is the corticospinal tracts, the subcortical white matter, and then the left brainstem in this case, because this was a right weakness. Then the spinal cord, then the lower motor neurons, the brachial plexus, the muscles, and the hand. But our second part of the diagnosis, a part of the localization, is the time course. In this case, if we have a hyperacute disease, we can think about a vascular process. We have an acute disease. Maybe we can think about a demyelinating disease or an abscess. Also, we have subacute and chronic processes. Then Aaron mentioned that there is a disease called Parsonage-Turner syndrome, which is an upper trunk brachial plexus, which causes severe pain in the upper arm and shoulder, which wasn't the case. Then Aaron also mentioned about CATASIL, which is part of mitochondrial diseases that can mimic a stroke. Then after Ravi presented a little more of the past medical history, the question was how to move forward. So this patient had a right weakness. So right weakness means that probably the lesion, if we think about the brain, is in the left brain. Also, we have to think about a multifocal process, because this was because one we have to think about multifocal processes or one big lesion enough to produce a bully and all the other symptoms. And with a focal lesion, we can think about an abscess, and with a multifocal lesion, we can think about demyelinating diseases. Both of these progresses faster than a tumor. So in top of our differential was an abscess and a demyelinating disease. So then before we had the exams, the question was what would help us on the exam. So the most important part in the neurology consult probably is the physical exam. So with this approach, we have to approach or assess if there is a gaze deviation, a frontal release signs, how is the language, also to check the cranial nerves and the reflexes, and the 2-point discrimination. Also, Aaron mentioned that if there is inattention, it is hard to test the memory. And if there is inattention, we can think more about toxic or metabolic diseases. And if there is attention with a language deficit, we can think about a localized versus diffuse process, which was all the concern in this approach, because we were thinking about if this was a localized or a diffuse process. So some clues about this was that there was clumsiness on rapid alternating movements. So with this, we were thinking about the cerebellum, but there was also a fluctuation in cognitive fluctuation, which make us think about a seizure or a demyelinating disease or a mass. So with this, we were thinking about a cortical process probably. So if we mix all these, we were thinking that we had an upper motor neuron process and a cerebellum, an upper motor neuron in the cortical part and in the cerebellum probably. So we were thinking again about a multifocal process, which was the final diagnosis. And also we have that transverse myelitis, which spans more than 3 levels. And we can think about some diseases, especially a MOG, which is an antibody-mediated disease previously called ADEM, Sjogren disease, NMO, or multiple sclerosis. Thank you so much for this case, Ravi, and all the discussion with this was very, very great.
Thank you. Excellent teaching points, Kiara. Thanks again, Ravi and Sridhara and Yasmin. Sorry we went over, but next time plan to bring a case or volunteer so we can start closer to 8, and I'll try to end closer to 9 as a result. But we had lots to talk about here. I hope you all learned as much as I did, and we'll see you next time. Have a nice day, everyone. Thanks again.